Chapter 8, Venipuncture Procedures. By the end of Chapter 8, you should be able to describe the patient identification process, explain the use of venipuncture supplies in a typical venipuncture procedure, describe when hand hygiene and gloving procedures should be used, identify the most appropriate sites for venipuncture and which sites may not be used, describe how to apply a tourniquet to a patient's arm and its effect on the venipuncture process. Describe the process for cleansing a venipuncture site. Describe the detailed steps of a venipuncture procedure. Describe the order of draw for collection tubes. Describe the importance of timed, fasting, and stat specimens. Explain at least 3 potential errors related to incorrect use of venipuncture supplies or equipment such as alcohol pads, tourniquets, specimen tubes, and needles. Describe what to do if a patient faints, feels nauseous, or has convulsions during a venipuncture procedure. Blood collection process. Essential steps common to all procedures. Each step must be evaluated carefully in a detailed manner. Take care not to omit any of the essential components. Steps. Prepare your work area, review test orders, prepare yourself through hand hygiene. Approach your patient and introduce yourself. Identify and position your patient. Assess physical disposition, diet, allergies, etc. Select and prepare equipment and supplies. Find, prepare, and cleanse your puncture site. Choose and perform a venipuncture method. Collect samples in the correct order. Discard contaminated supplies. Label samples and reconfirm patient's identity. Assess patient to assure bleeding has stopped. Perform hand hygiene after your procedure. Manage and document special circumstances. Prioritize patients and specimen tubes. Transport and/or store specimens appropriately. Using standard precautions. Overview. Hand hygiene and glove use should be routine procedures and well practiced for each patient, vital for well-being of the patient and the healthcare worker. Perform hand hygiene and gloving when in visual contact with each patient, before beginning, then glove removal, plus hand hygiene after the procedure. A clean, pressed uniform or scrubs with a laboratory coat is comfortable and instills professionalism and hygiene. Mentally preparing for the patient encounter. Prepare and assemble PPE, supplies, test request, pen, and appropriate patient information. Present a positive professional appearance and temperament. Take a deep, cleansing breath. Identify the patient properly. Wash or sanitize your hands and then put on your gloves. Great example. If patient information is incomplete, the healthcare worker may not be able to identify the patient correctly or may not know which tubes to use to collect the blood. In such cases, obtain assistance from a laboratory supervisor or a nurse before collecting the sample. Assessing, identifying, and approaching the patient. Test requisitions, transmitted electronically or on paper. If you don't understand the test ordered, consult a lab technician or nurse before the phlebotomy procedure. Knowing which tests are requested helps to prepare the patient appropriately and collect the specimen in appropriate tubes and in the correct order. Patient identification process. The Joint Commission recommends using at least 2 ways to identify patients: name, date of birth, government-issued ID with a photograph, for example, a driver's license. Identification not to be used include hospital room numbers, bed tags, charts and holders near a patient or on a table, or tags on IV equipment. 3-step process. Ask the patient to state and spell his or her full name and state his or her birth date. For example, "Sir, please state your full name and your date of birth and spell your last name." Compare the information stated with the patient's ID band. Confirm the information with the sample labels and/or requisitions. If all 3 identification steps indicate the same identity, Proceed with the collection procedure. Identifying the ID. Inpatient identification. Hospitalized patients, except those just entering an emergency room. Patients must wear ID armband with first and last name and unique hospital number. A three-way match must include the patient's statement and spelling of his or her name and birthday or address, the ID wristband, and the test requisition. Patients who are sleeping. A patient should be awakened to have their identity verified before blood is collected. Verbal information should be compared with information on the identification bracelet and the requisition labels. A nurse, relative, or friend may identify patients in these circumstances: unconscious or comatose, cognitively impaired, too young to identify themselves, cannot speak healthcare workers' language, have sensory impairments such as difficulty hearing instructions. Emergency room patient identification. Patients can enter the ER unconscious or unidentified. Temporary master ID is assigned, hospital number on the wristband, until a positive ID can be made. Temporary identification number is cross-referenced to the permanent number to ensure correct identification. Identification of neonates and babies. Confirm the following elements: name of the baby, if designated, date of birth, baby's gender, unique ID number, mother's last name or last name used at registration. A nurse or relative may confirm their identity. ID band is often placed on the ankle. Neonates do not always have a given name when born, so ID bands typically are linked to the birth mother. Use extra caution in cases of multiple births to not confuse identity of siblings. Outpatient ambulatory patient identification. Ambulatory patients usually come to blood collection area from the waiting room. ID process, verbally asking for the name, birth date, and to present identification. Positive identification using three-way match can occur in the same manner as with hospitalized patients. Physical clues for assessing the patient. Observe the patient's disposition by being alert and listen carefully. A clue about something unusual may come after talking to a patient or after the identification process has taken place. Diet, alcohol, medications, exercise, and/or smoking, tendency to faint, latex sensitivity, nausea, vomiting, or seizures. Stress, age, warm arm preference, and weight. Identify errors and high-risk situations. For example, multiple patients who are unconscious in the ER simultaneously, siblings or twins, newborns who have not been named, common or similar sounding names, multiple patients sharing a common room. Approach your patient. Politely knock on the patient's door. Introduce yourself and state your name, your department. Explain that you have come to collect a blood sample. Explain the procedure as supplies are being set up or as gloves are being put on. As supplies are being readied and the vein being palpated, healthcare worker may try to alleviate some of your patient's fears. Supplies for venipuncture. Being prepared means having all supplies readily available, organized, and in a clean, clutter-free cart, tray, or workspace. Supplies differ according to the method used and the test ordered. Ways to transport phlebotomy supplies. Figures A through D demonstrate several commercially available carts and trays ranging from basic trays to the use of mobile phlebotomy carts. Patient positioning. Make the patient comfortable and safe. Choose the least hazardous site for blood collection. Know about useful devices and the positions and locations of veins. Devices to assist in the positioning of the patient. Figure A is a typical phlebotomy chair with adjustable arms. Figure B is a recliner style chair with adjustable arms and/or shelves are available in a variety of styles, often with electronic height adjustments to facilitate the comfort and safety for the patient and the healthcare worker. Figure C. This is an example of an extra wide chair for a large or obese patient. Figure D. A phlebotomy wedge is available to help stabilize the patient's arm. It has an antimicrobial coating that does not absorb liquids and should be wiped clean and decontaminated after each use. Venipuncture site selection. Most common site for venipuncture is the antecubital area of the arm, just below the bend of the elbow. The median cubital vein, sometimes called the median vein, is preferred for venipuncture because it is reported to be less painful and less prone to injury. This is an example of the venous circulation. Phlebotomists must have an understanding of the anatomical positioning of the veins, arteries, nerves, muscles, and bones in both the right and left arms. For clarity, this diagram does not show bones and only shows hints of muscle placement, but it clearly identifies the approximate positioning of the veins, which are in blue, and the arteries in red. The nerves are in yellow, in relation to each side of the body. Each patient has an individual vein orientation or pattern, so phlebotomists should learn to palpate and select the most suitable and safest vein for access that has the least risk for complications. The second choice of vein is the cephalic vein on the outer edge of the arm. The last choice of vein is the basilic vein on the inner side of the antecubital area. Hand veins may provide an alternate site for venipuncture. Veins on the dorsal side, for example, the back side of the hand or wrist, are acceptable venipuncture sites if the antecubital veins are inaccessible. Ankle and foot veins on dorsal or upper side should not be used unless the healthcare worker is specifically trained and authorized to do so. If a patient complains of severe pain during the procedure, the needle must be removed immediately and the procedure must be discontinued. Accidental arterial puncture can result in the excessive bleeding and a hematoma formation. Vein variations in the hand and arm. Vein patterns are different for every person. Learn to feel the veins prior to venipuncture, not just simply see them. The examples shown in this figure are from people of varying races, ethnicities, gender, and ages. Some veins are visible and others are not. Note the variations in skin tone and elasticity or tightness, muscle mass, fatty tissue, and bone structure. For healthcare workers, the responsibility is to find the most suitable vein that has the greatest likelihood for a successful and safe venipuncture by relying on the feel of the vein, not simply how it looks. Dorsal or backside of the hand. Veins on the dorsal or the backside of the hand can be used for venipuncture. Note the arteries in red, the veins in dark blue, and the nerves in yellow, and the tendons are in light blue. Keep those structures in mind when performing a venipuncture on the dorsal hand. Figure B is the right hand of a 63-year-old female. Hand vein selection. After applying a tourniquet, the phlebotomist feels for dorsal hand veins. In Figure B, even though the veins are visible and palpable, they are more prone to rolling sideways during a venipuncture procedure. Note how the vein can be easily pushed to one side. In Figure C, the veins on the palm side of the wrist are not acceptable venipuncture sites. Arm veins cannot be used for venipunctures if intravenous or IV lines are in both arms, burned or scarred areas, areas with a hematoma, cast on an arm, thrombosed veins, edematous arms, mastectomy on one side only, mastectomy on both sides. Hard to find veins. Warming the puncture site facilitates the phlebotomy by increasing arterial flow to the area. Commercially available warming devices, clean towel, washcloth heated to 42 degrees Celsius will work as well. Position the arm in a downward position with the fingers pointed downward for about 1 to 2 minutes. This allows blood to fill the veins to capacity. Tourniquet application causes the veins to be more prominent and blood to fill the veins. A soft rubber tourniquet about 1 inch wide and 15 to 18 inches long is most comfortable for patients, affordable, and easy to use. After patient ID, hand hygiene, and donning gloves, select a clean latex-free tourniquet. Stretch the ends of the tourniquet around the patient's arm around 3 to 4 inches above the antecubital area. Here are some examples. Hold both ends of the tourniquet in one hand. With the other hand, tuck in a section next to the skin to make a partial loop with the tourniquet. The tourniquet should be tight but not painful to the patient. Do not leave it on for more than 1 minute. Do not place it over sores or burned skin. Depending on policies of each healthcare facility, it may be placed over a hospital gown sleeve. Palpate the antecubital area to locate and select the safest vein. Cleanse the area. Release the tourniquet after the needle puncture when blood has begun to flow into the collection tubes. During the venipuncture, release the tourniquet with one hand because the other hand will be holding the needle and the tubes. The partial loop should allow for easy release by the healthcare worker. Once released, it can remain loosely on the arm or the surface of the work area, for example, the bed or blood collection chair, until the procedure is completed. Cleansing the puncture site. Identify the patient properly. Wash or sanitize your hands using the appropriate agents. Dry them and then put on your gloves. Cleanse the site thoroughly with a 70% isopropanol alcohol pad. Rub the site with the alcohol pad using back and forth friction. If the skin is particularly dirty, repeat the process with a new alcohol pad. Air dry the site or dry it with a sterile gauze. Venipuncture methods. Evacuated tube system and winged infusion system or butterfly method. CLSI recommends venipuncture specimens be collected with a system that enables blood to flow directly into the tubes. Evacuated tube systems and winged infusion systems are widely available, equipped with safety devices, and comply with the CLSI recommendations. The syringe method. Syringes typically are made of plastic with graduated markings denoting their volume in milliliters. Useful for injecting fluids and medications, not recommended for routine venipunctures. Performing a venipuncture. The evacuated tube method. After greeting, identifying, and assessing the patient, cleanse your hands and don gloves. Assemble equipment in the presence of the patient. Double check the expiration dates and the integrity of all supplies. Offer to answer any questions. Prepare equipment according to manufacturer's instructions. For winged infusion or butterfly apparatus, the smaller needle 1/2 to 3/4 inch in length and 21 to 22 gauge in diameter comes attached to a thin tubing with a Lauer adapter for attachment to a tube holder. Position the patient's arm straight or slightly bent downward but in a comfortable manner. Apply the tourniquet and check for potential sites by palpating the vein. Feel for the median cubital vein first. If it does not feel suitable, remove the tourniquet and try the other arm. Cephalic vein is the next choice. Choose a vein that feels the fullest. If necessary, warm the site or lower the arm further in a downward position to pool venous blood. Cleanse the patient's skin with an alcohol pad in the back and forth motion. Allow site to air dry. Do not blow on it. Do not allow the patient to vigorously clench their fist or pump their fist because it can affect laboratory values. Caution the patient that he or she will feel stick and ask the patient to remain still while you begin the procedure. Remove the needle cap carefully. It cannot touch anything that would contaminate it. Position the needle parallel or running in the same direction as the vein. Insert the needle quickly with the bevel side up at a 30-degree angle or less with the skin. A slight pop should be felt as the needle enters the vein. Press the evacuated tube gently onto the sheathed needle. blood should begin to flow. If the blood does not flow, palpate gently above the puncture to feel for the vein and possibly reorient the needle very slightly. Do not probe. Release the tourniquet. If more collection tubes are needed, carefully remove the first tube from the holder with a gentle twist and pull motion and gently push the second evacuated tube into the holder so the tube closure is punctured by the inside needle and the blood can enter. Allow the blood to flow into the tube until it stops so that the proper dilution of blood to additive can occur. During the tube transfer, be mindful to hold the needle apparatus firmly and motionlessly so the needle remains comfortably in the vein during tube changes. Follow the correct order of draw. Blood stops flowing between tube changes because of the inner needle design, which allows a sleeve to block flow if it is not in use. Experienced healthcare workers can gently mix or invert a full tube in one hand while holding the needle apparatus in the other, waiting for another tube to fill. Some healthcare workers switch hands to use the dominant hand during the tube exchange. Use the method recommended by your healthcare facility, your supervisors, or your instructors. Find an approach most reliable, safe, and comfortable for both the patient and for you. When all tubes have been filled and removed from the holder, withdraw the needle, move it away from the patient, and hold the gauze pad over the site. The safety device that covers the needle should be used according to the manufacturer's instructions. Activate or cover the needle once it has been withdrawn, or manipulate a device that renders the needle blunt before the withdrawal from the vein. Instruct the patient to apply pressure to the site using the gauze. If needed, continue gentle inversion of the specimen tubes for complete mixing of additives with the blood. Remember, do not shake the tubes. Dispose of the entire needle apparatus in a puncture-proof biohazard container. Apply pressure until bleeding has stopped. Keep an eye on patient for signs of syncope. Label the specimens appropriately. Ask the patient to reconfirm their identity on the labeled specimens. Dispose of contaminated supplies and equipment. Double check that bleeding has stopped. Apply a bandage if appropriate. Wash or sanitize your hands. Thank the patient for cooperating. Depart with all blood samples and all remaining supplies. Do not leave anything at the patient's bedside. Deliver the samples to the appropriate locations for laboratory testing. Failure to activate the safety devices correctly as described by the manufacturers may result in a higher incidence of needle stick injuries. Here's an example. Performing a venipuncture with the winged infused butterfly method. It is most helpful in the following patients: those having tiny veins, pediatric or geriatric patients, patients who may have many needle sticks, those patients in restrictive positions with traction or severe arthritis, those with severe burns, those with fragile skin or veins, those patients who have specifically requested it due to less pain, those with short-term infusion therapy. It requires training and practice because of the small tubing attached to the needle. The tubing contains air which enters the first tube, thus it would underfill by 0.5 milliliters. Because this would affect the additive to blood ratio in some tubes, a non-additive tube should be filled first. After the first tube, the order of draw can follow the usual order recommended. The needle apparatus tends to hang loose on the end of the tubing and may recoil unexpectedly. Activate the safety device immediately after withdrawing the needle. Failure to activate the safety devices correctly as described by the manufacturers may result in a higher incidence of needle stick injuries. Performing a venipuncture using the syringe method. Syringes are not routinely used for venipuncture because of safety concerns, accidental cross-contamination of anticoagulants as blood is injected into multiple tubes, excessive forceful withdrawal of blood such that sample adversely affected, potential clotting in the syringe. Using the blood transfer device minimizes some of these problems. Syringes are useful for veins that collapse easily because of the pressure withdrawing the blood can be more gently controlled. Follow the same instructions for the greeting, assessing, identifying the patient, cleansing hands, and donning gloves. Assemble the supplies in the presence of the patient and offer to answer any questions. Prepare the equipment according to the manufacturer's instructions. Use the syringe needle with the safety device. Check the antecubital area for a suitable vein and apply your tourniquet. Cleanse the puncture site. Before the needle is inserted, move the plunger back and forth to allow for free movement and to expel all air. Use the same approach to the needle insertion as used for the evacuated tube method. Try to orient the syringe so that the graduated markings are easily visible. Once the needle is in the vein, draw back the syringe plunger slowly until the required amount of blood is drawn. Try not to accidentally withdraw the needle while pulling back on the plunger, and do not pull hard enough to cause hemolysis, which is the rupture of the cells, or to collapse the vein. After the tourniquet release and collection of appropriate amount of blood, withdraw the entire needle and syringe assembly quickly. Activate the safety device immediately, depending on the manufacturer's specifications. Remove the needle or winged collection set and discard it appropriately. Immediately fill the evacuated tubes for testing using a syringe transfer device. Carefully watch as the tube fills until it stops, which will ensure the correct ratio of blood to additive. Remove the first tube and replace it with the next one. Tubes should be filled in the same order as for the evacuated tube method. The blood transfer device. This image shows the healthcare worker inserting a tube into the blood transfer device after the needle with the safety device activated was removed from the syringe and disposed of properly. This image shows the wrong way to transfer the blood from a syringe into a collection tube. Note that the needle might have easily punctured the healthcare worker's index finger or thumb accidentally while holding the tube. Check the patient to see that bleeding has stopped. Follow the same directions for the rest of the procedure as in the other venipuncture methods. The order of draw for blood collection tubes. Multiple blood tests are often ordered on patients. Many tubes contain various additives. Collecting blood sample tubes in the correct order reduces chances of erroneous laboratory test results due to additive carryover from one tube to the next. Order of tube collection CLSI recommendations. Blood culture tubes have the yellow closure or vials. Coagulation tube with sodium citrate is the light blue closure. Serum tube with or without the clot activator, with or without gel, is the red or speckled closure. The heparin tube is the green closure, with or without the gel plasma separator. The EDTA tube is the purple or lavender closure. The glycolytic inhibition tube with potassium oxalate, sodium fluoride, or lithium iodocetate, heparin, has the gray closure. Here is the order of the draw and mixing requirements for multiple tube collections. Tip for the order of draw. If a laboratory test requires blood cultures, yellow, serum tubes, red, and heparin tubes, green, remember the phrase related to traffic lights: yellow light, red light, green light, go. Other issues related to filling the blood collection tubes. Minimize the transfer of anticoagulants from tube to tube. Be attentive to fill rate and volume in each tube. Ask for assistance in transferring blood to tubes. Closures and stoppers on sample tubes should not be removed to inject blood from the syringe. Specimen identification and labeling. Specimens labeled adhesive and/or barcode labels immediately at patient's bedside or ambulatory setting prior to leaving the patient. The labels must accompany all blood specimens. Tubes should never be pre-labeled because they may be erroneously picked up and used for another patient. Labels for blood specimens must include the patient's full name, patient's unique identification number, date of collection, time of collection, identification of the person who collected the sample. Assays to be performed, patient's room number, bed assignment, or outpatient status. That's optional. Issues affecting venipuncture practices. All disposable or contaminated equipment should be discarded into appropriate containers. To reduce incidence of iatrogenic anemia, processes should be in place for monitoring volume of blood collected from vulnerable patients. Methods are in place to reduce the likelihood of hematoma formation and hemolysis. All patients or parents and guardians for pediatric patients have the right to refuse treatment. At least one member of the staff should have first aid training. Guidelines for specimen rejection should be periodically reviewed. Leaving the patient. Visually scan all surfaces near the patient for extraneous supplies. Before leaving the room, wash or sanitize your hands. Check the puncture site to assure bleeding has stopped completely and that the patient does not feel faint. Apply an adhesive bandage if appropriate. Ensure that the tubes are appropriately labeled. Ask the patient to double-check sample labels indicate his or her name. Prepare the specimens for transportation. Thank the patient. Prioritizing patients. Timed specimens. If a test is ordered for blood sample collection at a particular time, the healthcare worker is responsible for drawing the blood as near to the requested time as possible. Fasting specimens. They require that blood be taken from a patient who has abstained from eating and drinking anything except for water for a particular period of time. Stat or emergency specimens. Stat blood samples are collected and delivered to the laboratory for testing as quickly as possible. The patient has a medical condition, possibly life-threatening, that must be treated to or responded to as a medical emergency. That's the end of Chapter 8. Thanks for watching.